Hi everybody, this is Dr. Parve. I'm going to be going over today how to read a chest x-ray. I am by no means an expert in reading chest x-rays, but I think it's important for the nurse practitioner to be able to at least look at a chest x-ray, have an approach, a systematic approach to reading a chest x-ray, and knowing if it's normal or abnormal. You might not know specifically why it's abnormal, like you might see something in the x-ray and be like, it's not normal, but I don't know what it is. That's okay, a radiologist will read it too. But you should be able to look at a chest x-ray and be able to tell something without just staring at it, not knowing what to do. So you will have some exam questions. They'll be from this lecture and from the YouTube video that I'll be showing you a little bit later on in this lecture. And we also have additional lectures available that I'll have posted in this week. They're from a radiologist that used to talk to the class for 2 weeks, actually. So we have about another 6 hours of lectures if you really want to know a little bit more about reading x-rays. And those lectures will go over more things like fractures and other abnormalities besides just a chest x-ray. So these are the top 10 reasons for ordering a chest x-ray. If somebody has acute respiratory cardiac disease and you can't find an old x-ray to compare it to or to look at to know what the extent of their disease is, or they haven't had anything recent. Say it's been, it was a couple years old and they're having some symptoms. Any major chest trauma, if they have any blood in their sputum, if they have chronic dyspnea and you suspect that they have some type of disease going on there. If you suspect they have a PE, pneumonia, CHF, a pleural effusion, or pneumothorax. And you will be getting more about the respiratory system in APN 2, so you're going to kind of know when you need to order these. If somebody has a positive TB skin test, you must do a chest x-ray to rule out pulmonary TB. If they have, if it's a neutropenic, febrile, immunosuppressed patient and they have new respiratory symptoms, then you need to do a chest x-ray. If they have persistent symptoms, and they've already been treated for a community-acquired pneumonia, which is also known as CAP, and they're still sick or they're still coughing, then you need to do another x-ray. What you will learn that sometimes if you have a patient that has pneumonia on chest x-ray, you should follow up anyway, because sometimes that pneumonia can cover up a nodule or a mass. You should also do an x-ray on anybody you suspect has a mass. If they have a lot of lymphadenopathy, and you're afraid that it's maybe metastasized a cancer that they have. And if they have a suspected elevated diaphragm. And I think this last one, number 10, is like, well, how would you know if they have a suspected elevated diaphragm, right? Well, you might see that on x-ray. So say you do an x-ray and then you see this elevated diaphragm, which we'll go over in a little bit. Well, they could have had a lobectomy, a pneumonectomy, they could have some phrenic nerve palsy, or they could have Mets to their liver. One thing that you will know for a suspected elevated diaphragm is something that you learned in physical assessment class, is you can always do percussion and also do the diaphragmatic excursion, if you remember that in your health assessment class. You do not need to order an x-ray for just anything routine. I know when you first become practicing, it's very tempting to order an x-ray pretty much when everybody has a cough because you're afraid you're going to forget something. And it's kind of normal, but I really wouldn't recommend it. Don't do it for routine pre-employment or somebody who's being admitted as a patient, but they don't have any respiratory symptoms. They just have a minor chest trauma with no pain, upper respiratory tract infection, uncomplicated acute exacerbation of asthma or COPD, acute or chronic chest pain, unless you're suspecting a PE, pneumonia, with pneumonia patients if there are no unusual clinical or radiographic features, and screening for lung cancer in asymptomatic patients. So you shouldn't just screen everybody for lung cancer because they smoked and they have a cough, or bronchitis. And don't forget that a thorough history and a chest thoracic exam will help you lead to your decision about whether or not you should order an x-ray. So there's a lot of debate about radiation exposure, and there is research on it too, showing that, you know, if you do a chest x-ray, you get this so much exposure. If you do a CT or an MRI, you get this much exposure. The bottom line is don't order if you don't need it. In other words, don't just randomly order chest x-rays because either you don't know what you're doing, which sometimes is what happens, or you're just not sure what's going on. Get a second opinion, do a more thorough history or physical on a patient, and then ask yourself, will this x-ray result change my treatment plan? So if somebody comes in and you suspect they have pneumonia and their pulse ox is fine, and you know their fever is maybe 100, 101, but they're doing okay, then you don't really need to do a chest x-ray on a normally healthy person who has pneumonia. You can just go ahead and treat them. So that if you do a chest x-ray and you were going to treat them anyway, you're really wasting the chest x-ray unless you're suspecting that there's something else going on. So let's just do a quick review of the thoracic anatomy. You should have had this in your health assessment class, and you will get it again next semester in APN 2. So you need to know the anatomy in order to know what you might be seeing on a chest x-ray. So hopefully you can either print this picture up or embed it in your mind so that you know when you look at a chest x-ray that this is how you're going to kind of be looking at the chest x-ray, and these are the structures that you're going to see to a certain degree. Okay, so this is just an overlay of the anatomy over a chest x-ray, so you can kind of see where everything's going to be. You'll also see I have a YouTube video embedded in this lecture that's going to go over a little bit more of this. In fact, it looks like they have similar pictures that I have that we got off the internet, but they're going to actually show them and then make them disappear with just the arrows, things that I don't seem to know how to do quite on the computer yet. For me, I'm a visual person, so to me this was a nice drawing that just kind of showed when you're looking at a normal chest x-ray or a chest x-ray, this is what you're going to be seeing as far as a cardiac silhouette, and you see your lung field, and even in the bottom here, the gastric bubble. So before we get too much further, I want to make sure that we remember where everything is when we're listening to the patient. So if the patient comes in, they have a cough, or they come in, they're short of breath, you're going to want to listen to their lung fields. And when you listen to them, this is what you're actually listening to. And I know this could be a little bit confusing when you're listening to lungs, exactly what you might be listening to. And then we're going to look at a chest x-ray so you can see where that coincides to the chest x-ray. The other thing that you can do without an x-ray is you can do fremitus. If you remember that, you put your hands on the patient's back and you have them say 99, 99. And you'll notice that you'll get decreased fremitus if there's an obstruction, a pneumothorax, or even emphysema. You might get that decreased fremitus. Or you might have increased fremitus if they have like pneumonia, which is something to do with a consolidation. And here's the posterior view of the chest. So if you're listening to a patient, remember the diaphragm does go up and down. So it depends if they're taking in a deep breath or if they're exhaling, where you're going to be hearing the noises on the bases, or the breath sounds on the bases. And please don't forget about percussion also, if you remember doing that in your health assessment class. So let's go over the ABCs of reading a chest x-ray. Before we do that, we have to make sure that it's a quality film. So you're going to get a different type of film if a patient's laying in a bed versus if a patient's sitting up or standing up. So that's the first thing you want to know. Was the patient laying down or was the patient sitting up? And I don't really have time to go through all of that, nor do I probably have the pictures to show you the difference between somebody who's lying down in a bed and somebody who's standing up. But anytime you can get them to stand up, you're going to get a much better view of the chest. So here's the mnemonic PIER. You should know that. I don't know that I'll have it on the exam, but I might. So you're going to want to know that for a couple of reasons. One, just because you need to know it for practicing and reading a chest x-ray. Okay, so let's start with A. A is for the airway, and I think you're going to be able to see my mouse, so I'm going to try and use it here. So here's the airway here, the trachea, and that should be midline and it should be patent. B is for the bones and the soft tissue. let me see if I can move this down here. So here's the clavicles coming across here. You're going to see the ribs here. You should be able to count 9 to 10 ribs if they have good inspiration. So where did my mouse go? Okay, so you can see 1, 2, 3, 4, 5, 6, 7, 8, 9. So, and you're always going to get more on the left-hand side because the diaphragm's a little bit lower. So I'm sorry, let's go over there. 1, 2, 3, 4, 5, 6, 7, 8, 9. Okay. In people with asthma, you're going to see less than that, or people that have emphysema or COPD, you might see less than 9 to 10 ribs. Okay, so the cardiac. So if somebody comes in with their pulse ox is low, you're going to suspect a couple things, and one of them might be CHF or cardiomegaly. So you're going to want to look at the heart. You can see here the heart on the right is a globular heart. One of the reasons I think that's interesting is I had a pediatric patient with that, and I ended up having to send them to cardiology. You can just see it's almost round. And then this patient over here on the left has cardiomegaly. So you can see if you're looking at the chest x-ray from here to here, it should only take up 50% of the space, and obviously it's taking up probably about 75%. In fact, let me go back once and see if I can. So see how this heart here, it's only taken up about 50%, and that's normal. That's how it should look. The other thing too is you're going to want to be able to see the heart borders, and they should be clear. You should be able to see them very clear. I'm going to go back again, sorry. As you can see, the right here and the left, you should be able to see those borders clearly. If you can't, that usually means that they have some type of consolidation pneumonia. And I don't believe I have an x-ray of that, but you're going to be able to, in practice, look at as many chest x-rays as you can. That's how you're going to learn how to read them. Okay. So D is the diaphragm. And usually what you're looking for is you're going to make sure it's not flat. And the other thing you're going to look for is air, free air. And you can see this is a really nice x-ray that's showing free air, which means most likely there's a hole in the intestine somewhere, causing this free air bubble to float to the top, as we would say. I also want to show you a picture of somebody with a hiatal hernia, and I've seen this in practice. Sometimes the symptoms include like frequent belching. I had this, I think she was an 80-year-old lady that said she couldn't eat very much and she was constantly belching, and I wish I had her x-ray because her stomach took up almost half her lung on the left side. So as you can see, right here is the stomach up into the chest. So the diaphragm's down here, but the stomach has moved itself up. And you can see because it's like an air kind of bubble thing, it's moved itself up there. So if you're looking at this, you might be like, oh my goodness, something's wrong with them. But if you look, that's air, because air is going to be either the black or the gray, the dark gray. As you can see, that's air. So then you have to think, okay, well look, it's coming from down here and it's kind of circular. Most likely that's a hiatal hernia. E is for effusions. So you're going to look at the pleura, and the pleura is on the outside here. And you're just going to want to make sure that there's no like spaces in between there where you're seeing either air or fluid. And then F is for fields and fissures. So you're going to check the lung field. I couldn't get a picture of it on here, but you're supposed to check the lungs actually last, because sometimes we get too distracted. If we're looking just at the lungs only, we might miss some other things. So you want to make sure that you look at the lungs last after you do the A, B, C, D, E. Okay, so F is last. Just a reminder, the right side is the patient's left. So as you're looking at this chest x-ray, your right side is really the patient's left. So it's almost like they're facing you. That's how you're looking at the chest x-ray. Thank goodness they put a big L up in the corner for some of us. You also might see breast shadows. So you can see down here, these shadows. You might be thinking, oh my goodness, they have something in their lung, because it's all kind of like whitish here, but this is their breast shadow. And somebody with a really heavy breast, sometimes it's going to be even darker than that. So let's talk a little bit about abnormal x-rays. I found this one online and I was looking at going, that looks like a bullet to me. So as you can see, if you're looking at this chest x-ray, you're thinking, what's wrong with this chest x-ray? You would go ahead and do your A, B, C, D's, E, and F's to look at this. Now you can see that their inspiration effort is not that great either. So, a couple things. We already talked a little bit about cardiomegaly. So here's a normal chest x-ray. You can see here's a gastric bubble down here. Actually, this is the gastric bubble, and this is intestinal gas. Somebody's got some gas going on here. So if you look up here, first you look at the normal one. You can see this is about 50%, which is normal of the lung field. But as you can see, this one is not. And yes, this is a very obvious one. You might not always get obvious ones. But with the not so obvious ones, you could take an older x-ray and compare it to a newer one and just see if that cardiac silhouette is bigger than it was before. As you can see here, you might be worried about this being some type of consolidation. Well, you can see a very clear outline of the heart here, and you can also see it over here. Here's an obvious one with somebody's got a mass in their right lung. So if you look here, see these clear borders, clear border, and then we have clear border, though they do have, looks like a lot of gunk in their lungs going on here. But as you can see here, there's not a clear border, and they have a large mass there. Let me tell you, most x-rays are not that obvious. Again, we talk about the heart borders. Obviously, we can't even see the heart there. This person has a pleural effusion. You can't see the heart borders, nor can you see the costophrenic angle down here. You can see it over here, but down here it is gone. So this patient has a pleural effusion. Okay, so here's the YouTube video I promised you. It's about a 10-minute video. And Dr. Eric will also discuss the lateral view, which I did not discuss with you guys. I really have a hard time reading lateral views for some reason. The good news is almost all of you will have radiologists available to read x-rays for you, or even the physicians can help you read them. But I would tell you in your clinical rotations in APN 1, 2, and 3, do whatever you can to read as many chest x-rays as possible. I know that I've read hundreds of them, and I still am not perfect at reading them. So anytime you can do it, even if it's after the patient left at the end of the day, if you can get your preceptor to pull up the chest x-ray and that you can look at it and then tell them what you think and then they can look at it. It's really a good way to get to learn how to read them. Otherwise, you're going to get out on your own. If you're like me when I worked at a rural clinic, I mean, I'm stuck reading them for a while until somebody finds a radiologist to read them. So I highly recommend you read and look at as many as you can. I will also at the end of this lecture have some more resources for you if you're really interested in radiology. I know some of you are. Then you can go and look at these videos and websites on your own time. Okay. So let's listen to Dr. Eric.
Hello everyone. This is the second video in this series on interpreting chest x-rays. The topic is the systematic approach and normal chest x-ray anatomy. The learning objectives of this video are to be familiar with the systematic approach to interpreting chest x-rays and to know the correlation between anatomy and normal shadows on the x-ray. Before just presenting a systematic approach, I first wanted to mention a couple of important principles about it. A systematic approach is most important for the clinician's least experience with reading chest x-rays, since it reduces the chance that important findings will be missed. All aspects of chest x-ray interpretation should be included. The individual elements of the approach should be examined in a sequence that's either logical and or easy to remember. And there is no one best system, though all should begin with an assessment of the film's technical quality. So the system I teach trainees is informally referred to as the ABCDEF system. It's not the only one, but it's certainly the most common, at least in the US. It's also not perfect, but it's easy to remember. Each of those 6 letters refers to a specific anatomic structure. Even before the A, we need to assess the technical quality. Then A stands for airways, B for bones and soft tissue, C for the cardiac silhouette and mediastinum, D for diaphragm, which also includes assessment of the gastric air bubble, usually located under the left hemidiaphragm, E for effusions, in other words, assessment of the pleura, which actually includes findings beyond just pleural effusions, and F for fields, that is, the lung fields. Lastly, although it's not explicitly part of the mnemonic, is an assessment of lines, tubes, devices, and prior surgeries, such as sternotomies and valve replacements. Aside from the fact that it's easy to remember, another nice thing about this mnemonic is that the lungs are examined near the end. This is a good idea because normally the lungs are the area of greatest interest and the most likely to be abnormal. Therefore, once the clinician finds an abnormality there, it's very easy for him or her to forget examining the rest of the film. I've seen more than one rib fracture missed due to distraction over acute lung pathology. You may have noticed that the list of items here lines up really nicely with the remaining videos in this series, which of course is not a coincidence. But before you can identify pathology of each of these anatomic structures, you first need to know where they are on the X-ray and what they normally look like. So let's go through the X-ray anatomy of A to F one at a time. A is for the airways. There are 3 anatomic airway structures that are typically visible on a normal X-ray. They are the trachea, which is normally in the midline, and the right and left main bronchus. Remember that the patient's right will be on the left side of the screen. To help you visualize these structures, let me superimpose a drawing of them. The left main bronchus tends to take off from the trachea at a slightly more horizontal angle as compared to the right, which is why aspirated foreign bodies, if small enough, are more likely to end up in the right lung than the left. And it's also why endotracheal tubes, if advanced too far, end up in the right main bronchus, blocking off ventilation to the left, rather than vice versa. I'll take the drawing away again so you can try to see the airways on your own. The next set of structures is the bones. There are 4 types of bones easily visualized on a PA and lateral X-ray set. First is this structure, which as you probably know, or could guess, is a rib. There are 2 radiographic components of the rib on the PA film. The posterior rib, which is easier to see and is oriented horizontally, and the anterior rib, which is harder to see and oriented at a 45-degree angle. The next bone is the clavicle, located up here. There's obviously a right and a left one. The sternum is sometimes visible on the lateral film, but is often obscured by soft tissue in the anterior chest wall. Then are the vertebral bodies, more easily visible on the lateral film, but usually seen on the PA as well, provided that the technical quality is adequate. Then there is the cardiac silhouette and the mediastinum, which I think logically should be evaluated together. There are a lot of anatomic structures which compose the silhouette here. I'll start by outlining it, and then label what each bump, knob, or side corresponds to. You will usually also be able to see another vertical line running just to the patient's left of the vertebral bodies, which corresponds to the left side of the descending aorta. To make it easier to visualize, here's a drawing of the heart and great vessels. The one structure on the patient's left, called the aortopulmonary window, may be unfamiliar to some viewers. This is an important space between the aortic arch and the pulmonary artery, where one will find the recurrent laryngeal nerve and lymph nodes. And then I'll take the drawing away and try to appreciate those various structures. Moving on, the diaphragm and pleura, which also makes sense to evaluate together. So here are the right and left hemidiaphragms, as seen on the PA view. It is normal for the right hemidiaphragm to be slightly higher than the left, presumably due to the liver directly beneath it. While looking at the diaphragms, it's important to remember that there aren't any truly flat structures in the body. For example, the hemidiaphragms are curved in three-dimensional space. As you might be able to appreciate from comparing the PA to the lateral, the hemidiaphragms as seen on the PA really just represent the superiormost aspect of the diaphragms. The pleura, which is a double membrane that surrounds each lung, is outlined here, but is normally invisible due to its thinness. However, knowledge that the pleura is there is essential for diagnosing a pneumothorax, pleural plaques from asbestos exposure, and pleural thickening. In addition, there are spaces on either side where the diaphragm meets the thoracic wall. These two spaces, seen on the PA, are usually called the right and left costophrenic angles, though the term costophrenic sulci would probably be more semantically accurate in most circumstances. The space in the back on the lateral film has several very similar names, the most common of which is the posterior costophrenic angle. There's also usually a small pocket of air visible under the left hemidiaphragm. This usually represents air in the stomach, in which case it's called the gastric air bubble, although occasionally it can be unclear as to whether the gas is in the stomach or in the intestines. Finally, the last structures on the chest X-ray are, of course, the lungs. The anatomic structures in the lungs to worry about when interpreting X-rays are the fissures between the lobes and the lobes themselves. First is the horizontal fissure located here. There's only one, and it's on the right side. Here is its location on the lateral film. It's the only one of the three fissures that is commonly visible in normal X-rays, which is because a significant portion of the plane of the fissure is parallel to the direction of the X-ray beams. However, it's only visible on the PA, which is why the fissure there is represented by a solid line, and the fissure on the lateral is represented by a dotted line. Then there are the right and left oblique fissures, neither of which is usually visible in either view. As you can probably guess, if you didn't already know it, the fact that there are two fissures on the patient's right means that the right lung is divided into 3 lobes, while the one fissure on the left divides the left lung into 2 lobes. Here's the location of the right upper lobe, and the right middle lobe, and finally, the right lower lobe. Notice that because the oblique fissure runs obliquely, as seen in the lateral view, the lower lobe extends almost all the way to the apex of the lung. This will be true on the left side as well. As a consequence, if only the PA or AP views are presented without a lateral, it's almost impossible to tell what lobe a visualized nodule or mass is located in, unless it's seen in the uppermost part above the lower lobe's most superior extent. Here's the left upper lobe, and finally, the left lower lobe. That concludes this video on the systematic approach and normal chest X-ray anatomy. If you found it helpful, please remember to like or share it. The next video will discuss the assessment of...
Sorry, I'm trying to figure out how to get to my next slide here. Okay. So he does have some more videos, YouTube videos. As you can see, they're very interesting. He has a lot of visual aids that I can't possibly get. So if you're really interested in knowing more, to dig deeper into reading X-rays, definitely I recommend that you watch his videos. And then this is a really good website where you can see a gallery of a lot of different types of abnormalities in chest X-rays and other X-rays. And sometimes people just like to look at that because they're interested in reading X-rays. So hopefully this has been interesting. And like I said, be sure to get out there and read as many chest X-rays as you can.